Hello guys, welcome to Pharma Guru. So first of all, I apologize for uploading this video too late. The reason is obviously we are all under lockdown, so that's the reason. So the topic that we are going to learn today is a very basic topic that I think we found is you cover this topic in our second year PharmD itself, that is the adrenergic. So we will begin with the basics only. So in today's video we will be dealing with only the basics, that is what adrenergics, what are the different types of adrenergic, what are the receptors where adrenergics bind. Nothing will be dealt about the drugs. We will be dealing about the adrenergic agonist and antagonist drug in the future videos. So let's begin with the basics. So first begin with the term that is adrenergics. The main thing that we should note here is this, that is the adre. Okay, so something that rhymes similar to adrenal gland, adrenaline, right? So yes, adrenergics are compounds that have the effect as that of adrenaline or noradrenaline, or we can call adrenaline and noradrenaline together as adrenergics. Fine, that's how this name came, adrenergics, from adrenaline. Now we will see whether adrenaline or non-adrenaline are same or not. This is a very basic confusion that we will have in our beginning, that it's adrenaline, next we are adding nor in front of adrenaline and saying it as noradrenaline. So whether these are opposite? No, they are similar compounds. Adrenaline and noradrenaline are having similar effect. Then why are we having two different names? That's the question. The reason is adrenaline is having more effect on the heart, right? Whereas noradrenaline is having same effect of that of adrenaline on the blood vessels. So that is the actual difference between adrenaline and noradrenaline. Adrenaline and noradrenaline are similar compounds. The difference is adrenaline is having more effect on the heart, whereas noradrenaline is having more effect on the blood vessels. Next thing, then what is epinephrine and norepinephrine? I'll tell you. Consider this as adrenaline, right? The same compound is also known as epinephrine. There is no other difference. These are not two different compounds. These two are the same compounds. Adrenaline, if this is adrenaline, this can also be called as epinephrine. If this is noradrenaline, this can also be known as norepinephrine. So to be very frank, adrenaline and noradrenaline, epinephrine and norepinephrine are same compounds. Just epinephrine is another term for the adrenaline. Norepinephrine is another term for the noradrenaline. Fine. Now we will see what actually adrenaline is. See, many of us will be having the doubt that whether adrenaline and non-adrenaline are hormones or neurotransmitters. I'll clear out this doubt. Adrenaline, or I will now say this combinedly as adrenergics. Okay, whenever I say adrenergic, I mean adrenaline and noradrenaline, or epinephrine or norepinephrine. See, if the adrenergics are produced by the adrenal medulla gland, okay, the adrenal medulla gland, it acts as a hormone. But certain nerve endings in our body can also produce these adrenergics. If the adrenergics are produced by the nerve endings, it is known as the neurotransmitter. That's the only difference. See, that's why we say adrenergics are both hormones as well as neurotransmitters. If the adrenergics are produced by the adrenal medulla, it is a hormone. If it is produced by nerve endings, it is a neurotransmitter. Now we are clear with this. We know what is adrenaline. What are adrenergics? Something related to adrenaline. What is adrenaline? What is the association between adrenaline and non-adrenaline? What is the is there any difference between adrenaline, epinephrine, or non-adrenaline, norepinephrine? No difference. Why do we term adrenaline different and non-adrenaline different? Because it has more effect on heart, it has more effect on blood vessels. We are clear with that. Okay, now we know that whether the adrenergics are hormones or neurotransmitters. If they are produced by adrenal gland, they are hormones. If they are produced by nerve endings, they are neurotransmitter. Simple. Now we will come across two important terminologies that we usually hear, right? It is sympathomimetic, right? What is sympathomimetics and sympatholytics, right? You all should have heard this across your curriculum, right? Sympathomimetics and sympatholytics, and I'm sure that many of the students still don't know what does it mean. Simple, guys. Read this term, mimetics. What does that mean? Mimic, same action. So if any compound that will produce same action as that of the adrenergics, that is adrenaline or noradrenaline, they are known as sympathomimetic. lytics. Generally, what does lytic mean? To break. Okay, so if any compound that will block the action of the adrenergics, it is known as sympatholytics, right? See, if I take a compound, whether if I take this compound, okay, this is a red one. If I take this one, it will go and bind to the adrenergic receptor and will produce the same effect that adrenaline or non-adrenaline would have produced. Then it is the sympathomimetic, right? Now if I'm taking this compound, it will go and bind to the adrenergic receptor and will block the effect that adrenaline or non-adrenaline would have produced. If it is blocking that effect, it is sympatholytics. So now we know all the basic terminologies that are required to understand the whole video. We know what are adrenergics, we know what is adrenaline, non-adrenaline, epinephrine, norepinephrine, whether adrenaline or the adrenergics are hormones or neurotransmitter. What do we mean by sympatholytics or sympathomimetics? Now, our main concern is not this hormone part. Our main concern is this neurotransmitter part. So now in this video we will see that how the nerve endings produces the adrenergics as neurotransmitters. Now we will see the mechanism of production of neurotransmitters, adrenergics. Okay, so now we will see how the adrenergics are produced by the nerve endings as neurotransmitters. Fine. So we will assume this is a nerve ending, right? A nerve axon, right? Now we will see this is also a nerve which is connected to an organ to which the effect has to be produced. Okay, consider that somewhere we here have a muscle or something like that, or a blood vessel. Okay, here we have a blood vessel. So what happens is, in our neuron we have voltage gated sodium channels. What we have? We generally have voltage gated sodium channel. So whenever the voltage gated sodium channels open and the sodium influx into the neuron occur, along with the sodium, one of the 20 amino acid that is tyrosine. The tyrosine will also enter along with the sodium into the nerve endings. Now as soon as the tyrosine enters the nerve endings, we have a specialized enzyme known as tyrosine hydroxylase. This tyrosine hydroxylase will convert the tyrosine into levodopa, right, inside the nerve ending. Now this levodopa will be acted upon by another enzyme that is known as aromatic amino acid decarboxylase, right? We know levodopa is an aromatic amino acid. So the levodopa will be converted into dopamine by aromatic amino acid decarboxylase, and this dopamine will be converted in the nerve ending into norepinephrine, right, the neurotransmitter, and these norepinephrine will be stored in these vesicles, right? We will be having many vesicles containing the norepinephrine. Now when these norepinephrines will be released, that's important. Consider that we have a kind of response or an action potential generated, right? We have an action potential or a situation where we have now to release the norepinephrine. Whenever there is an action potential, the calcium channels will open, and when calcium channels open, there will be heavy influx of calcium into the nerve endings, right? We will have calcium influx into the nerve endings. Now as soon as there is calcium influx and there is more and more amount of calcium in the nerve endings, what happens? These vesicles will slowly move towards the neuronal membrane, and these vesicles will bind itself to the neuronal membrane and then will break down and release the norepinephrine. Now why is norepinephrine released? Because there is action potential, there is influx of calcium into the nerve endings, which will force the vesicles to move towards the membrane, bind to the nerve membrane, and then open up and release the norepinephrine. Now where the norepinephrine is released, what is the gap between two neurons known as? Yes, the gap between the two neurons is known as the synapse. synapse, right? So the norepinephrine is then released into the synapse. Now what actually happens to this norepinephrine? Three possibilities is there. First thing is, this norepinephrine will get back into the neuron, right? This is possible, and this is known as the negative feedback. This is known as the negative feedback mechanism. So what happens when this norepinephrine gets back into this? there is an enzyme that is known as monoamine oxidase. What is that enzyme known as? Monoamine oxidase, right? We all have come across this term, monoamine oxidase. What term, monoamine oxidase inhibitors drugs, right? So what happens is, these neurotransmitters or norepinephrine through negative feedback mechanism enters into the same neuron, and this monoamine oxidase will act upon this and will convert it into its inactive metabolites, right? That is the negative feedback mechanism. Next thing is, some of the norepinephrines will be acted upon by another enzyme that is present in the synapse, and those enzymes are known as COMT. Yes, you all know the full form of COMT, right? Catechol O methyl transferase inhibitors. We have learned that drug, right? Catechol O methyl transferase enzyme. So some of the norepinephrine through negative feedback will enter into the same neuron. Some of the norepinephrine will be converted into inactive form by an enzyme known as catechol O methyl transferase, and this inactive compound will be then released into the systemic circulation, right? Now the third thing that is going to happen to this norepinephrine is, these norepinephrine can bind to the receptors. So three things that can happen. First one is negative feedback mechanism, and the enzyme involved is monoamine oxidase enzyme. Second mechanism that is going to happen is converting into inactive form and throwing it away into the systemic circulation by an enzyme known as catechol O methyl transferase. And the third thing that is going to happen is that these norepinephrine can go and bind to the receptors. And these receptors is what I talked earlier are the adrenergic receptors, right? These are the receptors that we called as the adrenergic receptors. And when these norepinephrine or the any, whether it be epinephrine or norepinephrine comes and bind to these adrenergic receptors, it will produce a response. We know whenever a neurotransmitter comes and bind to the receptor side, it will produce any response. So this is how the adrenergics, that is the norepinephrine or epinephrine, are produced at the nerve endings. And one thing that I'll say is interesting is, what these receptors are? The adrenergic receptors. What are the two types of adrenergic receptors? Many of you may not be knowing, but when I say the names, you will say, wow, this is adrenergic receptor. Yes, obviously guys, the alpha receptor and the beta receptors. We all have come across the drugs, right? Alpha blockers, beta blockers. So these are the receptors, alpha receptor and beta receptors. So now we know that how the the adrenaline or non-adrenaline are produced as neurotransmitters in the nerve endings. Now we will focus on these, the receptors, the adrenergic receptor, whether it be alpha receptor or the beta receptor. So as we have covered everything, that is adrenergics, how is the neurotransmitter adrenergic produced. Now we will see where this binds. As we have said, it will bind to the receptor. Which receptor? Adrenergic receptor. What are the two types of adrenergic receptor? Either the alpha receptor or the beta receptor. So by convention, we will first talk about the alpha receptors, right? We will talk about the alpha receptors. So the alpha receptors are mainly of two types, right? Either alpha 1 receptor or the alpha 2 receptors. The alpha receptors are again classified into alpha 1 and alpha 2. Now where are the alpha 1 receptors found? The alpha 1 receptors are primarily found in the vascular smooth muscles. Vascular smooth muscles means the smooth muscles that are present on the blood vessels. So the alpha 1 receptors are primarily found on the vascular smooth muscles. It is also found in the iris, right? It is also found in our kidney, found also in the liver, as well as it is also found in the bladder. So if someone asks you where will you find alpha 1 receptors, I'm going to hide this. What are the 5 places where alpha 1 receptors are found? First one is vascular smooth muscles, second one is the iris, third one is liver, kidney and the bladder, right? These are the places where alpha 1 receptors are found. Now take for instance that the adrenergics in our body will stimulate these receptors, right? If it stimulates the alpha 1 receptor in the vascular smooth muscle, what will it cause? It will cause vascular contraction. If it stimulates the alpha 1 receptor in the iris, it will cause pupillary dilation. Okay, if it stimulate the alpha 1 receptors present in the kidney, it will inhibit the renin production. If it stimulate the alpha 1 receptors present in the liver, it will cause glucose release, right? And if it stimulate the alpha 1 receptors present in the bladder, it will cause bladder contraction. Okay, so where are alpha 1 receptors found and with its function, what if the alpha 1 receptor is stimulated? First one is vascular smooth muscle, will cause vascular contraction. Second one is the iris, it will cause pupillary dilation. Then in the bladder, if it is found, it will cause contraction of the bladder. In the liver, it will cause increased glucose release. In the kidney, it will inhibit renin. So that is all about alpha 1 receptor. Now alpha 2 receptors. Trust me, alpha 2 receptors is not of much clinical significance, but still we will learn something about it. Is alpha 2 receptors are prominently found in the central nervous system. Other than that, in the pancreas, right? It is present in the pancreas. So what if the alpha 2 receptors present in the pancreas is activated? It will cause reduced insulin release, right? If we want the patient not to release more insulin, if the patient is already hypoglycemic, if we do not want more insulin to come and break down the glucose, we will activate the alpha 2 receptors that will reduce the insulin production. But still it is not of that of clinical significance. So the alpha receptor that is mainly of clinical significance is the alpha 1 receptor. Quickly revise where the alpha 1 receptors are found: in the vascular smooth muscle. Where it is stimulated, it will cause contraction. In the iris, if it is stimulated, it will cause dilation. In the kidney, it will reduce the renin production. In the liver, it will increase glucose production, and in the bladder, it will cause contraction. So obviously the second class of receptors are the beta receptors, right? We have the beta receptors. See, alpha receptors were classified into 2 types. We have beta receptors classified into 3 types. What are the 3 types? If it was alpha 1, alpha 2, it should be beta 1, beta 2 and beta 3 receptors, right? Now, this is more important that of alpha receptors in case of many diseases also. So where will we find? We'll start with beta 1 receptor, okay? Where will you find beta 1 receptor? You will find beta 1 receptors prominently in the heart. Where will you find? In the heart, right? We will find the beta 1 receptors prominently in the heart, along with some of the beta 1 receptors are also present in the kidney. Now what happens is, whenever the beta 1 receptor is stimulated, what happens in the heart? There will be increased heart rate, right? If any of the adrenergics, whether it be epinephrine, norepinephrine, or what we say as adrenaline or noradrenaline, if any of these comes and bind to the beta 1, see, I have said whether adrenaline is more cardiospecific or noradrenaline. Obviously adrenaline. So if adrenaline comes and binds to the beta 1 receptor present in the heart, what happens is there will be increased heart rate, there will be increased conduction across the heart, right? And there will be increased contraction. If the beta 1 receptors in the heart is activated, it will cause increased heart rate, increased heart contraction and increased conduction across the heart. What will it lead to? Whenever there is increased heart rate, more blood will be pumped, so blood pressure will rise. So we want, if a patient is having hypertension, we do not want this to happen, right? So what will we do? We will block the beta 1 receptor, right? We will block the beta 1 receptor. That's why we give drugs such as beta blockers, atenolol, propranolol. Fine. These beta 1 receptors are present in the heart. If they get activated by adrenaline, heart rate will increase, simultaneously blood pressure will again increase. So we do not want the heart rate to increase. We will block the beta 1 receptor and we will stop the adrenaline from binding to beta 1. So beta 1 receptors are primarily found in the heart. I said it is also found in the kidney. So what happens when it binds to kidney? When beta 1 receptor in the kidney is activated, it will produce more renin. And as I said, whenever there is increased renin level, what happens is blood pressure goes up. So we do not want more renin to come if the patient is hypertensive. So beta blockers will block both the beta 1 in the heart as well as the kidney. So beta 1 receptors are found where? Mainly in the heart and the kidney. In the heart, it will cause increased heart rate, contraction of the heart and contraction of the heart. So we want to stop all these effects in case of hypertensive patient. That's why we give beta blockers, right? So beta 1 receptors are cardiospecific receptors because it is mainly found on the heart, right? Beta 2 is not as much that of selective. The beta 2 receptors are primarily found in the lungs. Not only in the lungs, it is also found on the vascular smooth muscles, right? Alpha 1 is also found in the vascular smooth muscle. Beta 2 is found in the vascular smooth muscles. It is also found in the gastrointestinal tract along as well as the pancreas. Not that important, okay? So beta 2 is found where? First, lungs, vascular smooth muscles, gastrointestinal tract and the pancreas. So we will take these two as important. So what happens when the adrenergics comes and bind to the beta 2 receptors present in the heart? It will cause bronchodilation. It will cause bronchodilation. When it comes and bind to the vascular smooth muscle, it will cause dilation. So see, this is very interesting, okay? What if I give a beta 2 drug? If I am giving a beta 2 agonist drug or the adrenergics, what happens is it will bind to the beta 2 receptor and will cause dilation in the lungs, that is bronchodilation and vascular smooth muscle dilation. Okay, this will bring down the blood pressure. What if I give beta blocker, beta 2 blocker? If I give beta 2 blocker, this dilation will not occur. So what happens? The vascular smooth muscles will constrict, increased blood pressure. So if you want to raise the blood pressure of a patient, you will give beta 2 blocker. If you want to reduce the blood pressure of a patient, you will give beta 1 blocker. Fine, right? But there is a condition where you would like to increase the blood pressure of a patient and you cannot give beta 2 blocker. Where, you know, if the patient is having any respiratory problems such as asthma or COPD, why? You will give beta 2 blocker, it will come and block the beta 2 receptor in the vascular smooth muscles and constrict the blood vessels and increase the blood pressure. Fine. But it will also constrict the lungs, which will make the condition of asthmatic or COPD patients worse. Okay, just leave that. That was just an extra point. So beta 2 receptors are more found in the lungs as well as the vascular smooth muscle. Both the areas it will cause dilation. Right. Now the beta 3 receptors, it's not of much importance, but interestingly it is found in the urinary bladder. Mainly it is found in the urinary bladder. And whenever it is activated, it will lead to reduced urination. Okay, it will lead to reduced urination. Now in which case we would like to do this? If the patient is, you know, an old age patient, a geriatric patient, and if the patient is not having a control on his urination, he will frequently urinate without his knowledge or permission, right? So in that case, we will stimulate the beta 3 receptors of such patients, and when the beta 3 receptors of such patients are stimulated by any drug, it will cause reduced urination. I'll name one drug. It is mirabegron. MIRABIG-RON. So this is a beta 3 agonist drug. It has same effect as that of the adrenergics on the beta 3 receptor. So if we give mirabegron to old age patients or the geriatric patient, there will be reduced urination. So that's all about the receptors. So we will quickly recap the receptors because that is more important. So let's recap from the first of the video. What we learned is what is adrenergics, what is adrenaline, non-adrenaline, difference between them, right? Whether adrenergics or the adrenaline and non-adrenaline are hormones or neurotransmitters. Okay, if it is produced by the nerve endings, it is neurotransmitter. It is produced by the gland, it is hormone. And then we learned how the neurotransmitter is produced from the nerve endings, right? We saw all the mechanisms from tyrosine to levodopa to dopamine, then to norepinephrine, then calcium comes in, it binds and then releases into the synapse, then it negative feedback mechanism returning back into the neuron, then it is again metabolized by catecholomethyltransferase and inactivated and sent into the systemic circulation. Then it can also bind to the receptors on the affected organ. What are those receptors? Known as adrenergic receptors. Adrenergic receptors again of two types, alpha and beta receptors. First we will talk about alpha receptors. Alpha is again of two types, alpha 1, alpha 2. Where are alpha 1 receptors found? Vascular smooth muscles, iris, bladder, kidney and the liver. So in vascular smooth muscle it will cause constriction. In case of iris, it will cause pupillary dilation. In case of bladder, it will cause contraction. In case of liver, it will produce more glucose. In case of kidney, it will produce less renin. Then we'll talk about alpha 2 receptors, which is not of that clinical importance, but still the alpha 2 receptors are found in the central nervous system along with the pancreas. In the pancreas, if it is activated, reduced level of insulin will be synthesized, which we'll try in case of hypoglycemic patient, but still it is not of that clinical importance. The next one is the beta receptors, that is more important clinically. Beta receptors are classified into 3 types: beta 1, beta 2 and beta 3. Where are beta 1 receptors found? We will call beta 1 receptors as cardio-specific receptors. With that clue, we know beta 1 receptors are mainly found in the heart. Along with that, it is found in the kidney. If the beta 1 receptor in the heart is stimulated, what happens? There will be increased heart rate, there will be increased cardiac conduction, there will be increased cardiac contraction, and due to this, blood pressure can rise up, right? If it is activated, if the beta 1 receptor is activated in the kidney, there will be increased renin. When renin is increased, renin-angiotensin-aldosterone system will be activated, which will lead to increased blood pressure. So whenever beta 1 receptor is activated, blood pressure will go up. That's why for antihypertensive patient, we will block the beta 1 receptor, right? We will give beta blockers. Then we have beta 2 receptors. Beta 2 receptors are mainly found in the lungs along with the vascular smooth muscles. Both areas, whether it be lungs or smooth muscle, it will cause dilation. In the lungs, it will cause bronchodilation. In the blood vessels, it cause vascular dilation, right? And the beta 3 receptors, mainly it is not of much importance, but it is primarily found in the urinary bladder. If the beta 3 receptor is activated or stimulated, it will cause reduced urination. Where will we use it? In case of geriatric patient who cannot control their urine release or the bladder. So one drug that I have mentioned is mirabegron. It is a beta 3 agonist. Mirabegron will stimulate the beta 3 and will reduce the urine release. So that's all. Now we have clearly understood the basics about adrenergics, hormones and everything, and in the next video we will be dealing about certain drugs that are related to adrenergic. We will deal about adrenergic agonist drug, that is alpha agonist and beta agonist. We will deal about adrenergic antagonist drug, that are alpha blockers as well as beta blockers, or we can call it as alpha antagonist or beta antagonist. So that's it for today's video. We'll coming up with the next video. Stay tuned. If you haven't subscribed Pharma Guru channel, please do go and subscribe by clicking the red button, and please do press the bell icon so you get all the notification of all our new updated videos. Till then, take care, stay safe and keep learning.